Hello, and thank you for joining us for today's National Asian Pacific American Caucus of State Legislators webinar, Cardiovascular Disease in AAPI Communities. My name is Irene Kawanabe, and I serve as the Staff Director to the National Asian Pacific American Caucus of State Legislators. I'd like to introduce today's moderator, Representative Ryan Yamane from Hawaii. Representative Yamane serves as the co-chair of NAPACSL's Health, Human Services, and Housing Committee. I'll turn the program over to Representative Yamane.
Thank you, Irene. Let's get to why we're here today. Gaps in data widely exist among Asian Pacific Islander subgroups when it comes to cardiovascular disease. Nationally, heart disease is the leading cause of death. Nearly half of all people in the United States have at least one of three risk factors that lead to CVD. Recent studies from the American Heart Association show that South Asians in the United States are more likely to die earlier from heart disease than other racially or ethnic groups. We will hear from medical professionals on the latest data and strategies to prevent and treat cardiovascular disease and ways to engage with state health departments. If you have any questions for the speakers, please email Irene at irene.kawanabe@ncsl.org. Joining us today are Dr. Stanton Shanling, Dr. Kazuma Nakagawa, and Dr. Alka Kanea. Our first speaker today is Dr. Stanton Shanling. Dr. Shanling has been the supervisor of the Cardiovascular Disease Unit at the Minnesota Department of Health since 2005. In this role, he advances the department's agenda to improve cardiovascular health and reduce the burden of heart disease and stroke across Minnesota. Dr. Shanling will share with us ways policymakers can work with state health departments to address cardiovascular disease. Dr. Shanling, thank you so much for joining us today. The floor is now yours.
Thank you so much for having me. I greatly appreciate it, and it's wonderful to talk to people around the country. So thank you for this opportunity. I've been asked to give my perspective of how it is that legislators and various colleagues from around the country can engage with their states in enhancing cardiovascular health in creative ways and connecting with such things as state plans, etc. It's an interesting thing to think about when you're trying to promote health for people, especially around particular chronic disease such as heart disease and stroke. The key is, in my estimation and based on my experience, is to reach out to your cardiovascular health leadership at your state health departments. Make it a two-way conversation. Know that it is really the key to getting information to one another is knowing that you have trusted colleagues and professionals that can really help you, and know that it's one-stop shopping as far as information exchange. With data that's provided by your specific health department, you will have a better understanding of the prevalence of cardiovascular disease for the state overall and for any particular disparate population group. With that in mind, if indeed your state has a voluntary cardiovascular health advisory alliance like we do in the state of Minnesota, I would volunteer at two different levels. One is to either be a formal member of that committee or an ad hoc member of that committee, whereby you'll be able to connect with various colleagues that are really the most knowledgeable about this particular chronic disease. And it'll be basically a really good avenue for information exchange almost on the fly and as you need it. If your interests, and this is kind of funny when I say this, if your interests are policy driven, which I assume they are, focus on sustainable efforts. The work we are involved with in cardiovascular disease and cardiovascular health requires behavior and norm changes for a lot of people. For norm changes to take place, data indicates, and the literature indicates, that it can take up to 30 years for an actual norm to change in a particular, for a particular population. This requires going beyond a typical legislator's tenure in office. And I say this with all honesty, you have to carry the torch beyond any particular time that you are seated in office, because frankly, the chronic diseases will continue on one way or the other. If, and there should be, a cardiovascular health state plan, ours in the state of Minnesota is in development. It'll be a 2030 state plan. We are doing it in collaboration with diabetes, which is also something that I would highly recommend, since these are very complementary as far as risk factors are concerned. If you do forge ahead with a state plan, I would highly recommend that you complement the objectives that are laid out in Healthy People 2030, the objectives for the nation, which has already been published. So I would encourage you to go to that site, healthypeople2030.com, to see what particular objectives are established around cardiovascular health and disease that also include health equity and focusing on disparate population groups. I would underscore being aware of the risk factors for cardiovascular disease for your population. Know the values that your population has and how together along with these risk factors, they can lead to change. Each population group has their own values. It's laden in their history, in the stories that they tell to one another, how they engage health overall. So I would encourage you to be aware of that. The arenas in a state plan are pretty straightforward. They should include prevention, which really includes things such as education and messaging. Acute treatment, which is actually the easiest of the arenas, frankly, because acute treatment is often connected with standards of care and guidelines that are already established. So once somebody presents themselves into the ER with a potential heart attack or stroke, guidelines and protocols are really put into place on how to treat that person. And then finally, disease management is, fortunately, if they're fortunate enough to have lived through a stroke or a heart attack, then it becomes a disease management focus, where we focus on things such as hypertension control, cholesterol management, and other lifestyle things such as obesity and exercise. So again, all of these strategies can be laid out in a state plan if you so choose to proceed that way. Then finally, I have a couple of other points here quickly, is note the difference on outcomes. Everybody wants to, especially if there's money that's put into an initiative, what's the outcome for it? Well, there are quantitative outcomes where we can be real numbers driven, or there are qualitative outcomes. I would argue that both are very, very important, especially when you're dealing with particular populations that are value laden and have a lot of history behind them. Finally, and probably the most important point that I will make for you as legislators, and certainly given our most recent emergency around COVID, is fund public health. I will say that over again. Fund public health. It will pay off in dividends for you, your constituents, your family and friends, and for the future. If you fund public health, you can also complement that with funding chronic disease and be strategic. We should not, nor should we ever be in a situation that we are struck or surprised by the need to be reactionary. We should not have to be reactionary. If we are strategic in addressing our ongoing health needs, we will be ahead of the game always as it relates to the health of our constituents and of the nation as a whole. So with that, I'll turn it over, and I'll be happy to answer any questions that come this way through email or whatever. I'll be happy to circle back with all of you. Thank you for the opportunity. It's been a pleasure.
Thank you, Dr. Shanling. Next up is Dr. Kazuma Nakagawa, a neurointensivist and vascular neurologist at the Queen's Medical Center and Associate Professor of Medicine for the University of Hawaii, John A. Burns School of Medicine. After starting an academic career as a clinician scientist at the University of Hawaii and the Queen's Medical Center, he has identified a new area of research interest: investigating the racial disparities in risk factors and outcomes in stroke patients among Native Hawaiians and other Pacific Islanders. Dr. Nakagawa, thank you so much for joining us today. The floor is now yours.
Thank you for the kind introduction. I'm going to share my screen now. Can you guys see the screen okay now?
Yes, we can.
All right, well, it is my true pleasure and honor to be invited here today to give a brief presentation entitled Cardiovascular Health Disparities Among Asian Americans. Although I genuinely care about the cardiovascular health as a whole, my clinical specialty is in stroke, so this presentation may have a little bit of a bent towards stroke. When we picture Asian Americans, the stereotype is that they're healthier than the non-Asians in the United States. Perhaps it's because they are generally thinner appearing than the non-Asians. Since obesity is associated with increased risk of cardiovascular disease, lack of obesity is often perceived by public as being healthy. In fact, if you look at the Asian population as a whole, they do appear healthier than the non-Hispanic whites. This figure here shows that the age-adjusted heart disease mortality rates are much lower, almost by half, compared to the non-Hispanic whites. Similarly, the age-adjusted prevalence of high blood pressure among Asian Americans as a whole seems lower compared to the non-Hispanic whites. These aggregated data have led many of us to have this impression that Asian Americans are healthier than other ethnic groups in the United States. However, more recently, the experts have started to question that stereotype. Now, we know that the body mass index, or BMI, the index for obesity, should be interpreted with caution for the Asians. For the same amount of body fat, age, and sex, Asians tend to have a consistently lower BMI by about 2 to 3 kilograms per meter squared in comparison to whites, partly due to just the biological differences in body build and muscle composition. Therefore, even though the definition for obesity traditionally has been BMI over 30 for the general population, the World Health Organization now defines obesity for Asians to be BMI over 27.5, a couple points lower than the traditional number 30 to account for these differences. We're now learning that Asians who may not appear obese externally could still have high burden of cardiovascular risk factors such as diabetes, hypertension, and high cholesterol, and may be impacted by heart disease and stroke. More recent studies are showing that as an aggregate group, Asians in America appeared healthier than the non-Hispanic whites. But when researchers disaggregated the data, they uncovered a number of disparities. It was surprising to see that Vietnamese people reported worse health, twice as worse compared to non-Hispanic whites and Asians overall. Japanese respondents had a higher proportion of people who reported obese or overweight than non-Hispanic whites. And Japanese and Koreans reported higher rates of diabetes than non-Hispanic whites and just general Asian population. If you use a traditional BMI threshold of 30 for the non-Hispanic whites, African Americans, and Hispanics, and use the Asian-specific BMI cut point of 27.5 for Asians, and define obesity and overweight that way, you can see here that the proportion of population with obesity, which is shown in dark gray, and overweight shown in light gray, are very similar compared to the non-Asians, or even higher among Asians, such as Filipinos, compared to the non-Hispanic whites. What's more shocking is that if you look at the diabetes rate that are normalized to age and BMI, the rate of diabetes per 100,000 population is significantly higher among all Asian ethnic groups compared to non-Hispanic whites. And these numbers are highest among Filipinos and Indians. More notably, we now know that South Asians are the highest risk Asian subcategories. We now know that South Asians have 4 times the risk of having heart disease compared to the general population. Some of the research have shown that 25% of heart attacks occur under age 40 for young South Asians. And 50% occur under age 50. That's very young. Overall, South Asians develop coronary artery disease up to 10 years earlier than the general population, a decade younger. And this theme is true for other conditions as well. This is a more granular view of looking at age-adjusted cardiovascular mortality among various South Asian ethnic groups. Here, you can see the variation among the different South Asian ethnic groups as well. Therefore, it is time to disaggregate Asian Americans and Pacific Islanders from a single ethnic group and look at each ethnic group separately. Globally, over the past 2 decades, deaths from cardiovascular disease have been declining in developed nations, which you can see in the yellow and green color, but have rapidly increased in the low and middle income countries, most notably in Russia, Africa, South and Southeast Asian countries, where you can see in orange and red. This is another way of looking at what has been happening globally over the past 3 decades. This is the percent change in stroke incidence between 1990 and 2010 over a 20-year period. The blue and green color indicates that there had been greater reduction in stroke incidence over 2 decades, while red and dark red indicates that there had been little reduction or perhaps increase in stroke incidence. You can see the dark color red is highest in that same countries: Russia, Africa, South Asia, Southeastern Asian countries. Another ethnic groups that have been historically aggregated with all the Asian groups are the Pacific Islanders. Here's the map of US with the states that have the highest proportion of Native Hawaiian/Pacific Islanders based on the Census Bureau. According to 2017 US Census, there are roughly 1.5 million Native Hawaiians/Pacific Islanders alone within the United States, with the highest proportion in Hawaii, with an estimated number of 367,000 Native Hawaiians or Pacific Islanders. Hawaii is one of the most ethnically diverse states in the United States, with 37% of the population being Asians compared to 27% Caucasian whites. And we have approximately 10% Native Hawaiian and other Pacific Islanders. The data from the Hawaii Department of Health, which specifically addressed the status of the heart disease and stroke, demonstrated that stroke remains to be the 3rd leading cause of death in Hawaii, while it has dropped to the 5th leading cause of death in the mainland United States. Worldwide, stroke remains to be the 2nd leading cause of death. So you can see here that there is a disparity in burden of stroke in Hawaii compared to the mainland US. Within Hawaii, there are ethnic differences in stroke mortality. Here you can see that Native Hawaiians and Filipinos, seen on the 2 left bar graphs, have higher rates of death compared to non-Hispanic whites and Japanese American. Our group, also using statewide database, show that Filipinos have the highest rate of in-hospital mortality after stroke. When I first came to Hawaii in 2010, 10 years ago, this was one of the first cases I saw. A 27-year-old Native Hawaiian man with early onset of hypertension who came in with a disabling hemorrhagic stroke. You can see in that picture that the brightness, the spot in the brain that's on the left side was the bleeding that happened. He was 27. We did extensive workup, but it turned out to be the traditional just high blood pressure that occurred early that was uncontrolled. And I was shocked to see how young this man was. At the time, I did a literature search on racial disparities in hemorrhagic stroke, and I was shocked to see that there was no single paper published among about Native Hawaiians. This is what I found in 2010. This was the age of a hemorrhagic stroke. You can see we had a data on non-Hispanic whites, Hispanic Americans, African Americans, and Maori Pacific Islander in the Pacific, but that was about it. So our project was to look at our own data and show that Native Hawaiians and Pacific Islanders' age of onset for hemorrhagic stroke was much younger, again, about 10 years younger. You can see in this graph that the bell curve shape of the age distribution has shifted to the left for the Native Hawaiian Pacific Islanders, which you see on the black bar. This is the table that showed that mean age of onset was 55 for the Native Hawaiians Pacific Islanders compared to mid-60s in the Asians and non-Hispanic whites. Again, a decade younger, 10-year gap. We were able to publish that finding in 2012, and we were able to add our local population data from here to there. And you can see that our Native Hawaiians and Pacific Islanders are the youngest among all the other ethnic class in this stroke population. We were fortunate to establish a partnership with the Department of Native Hawaiian Health from the University of Hawaii to do a joint research, which led to the cohort study where we followed these population over time, and again demonstrated the 10-year gap. They're definitely having strokes 10 years younger. We also found some social determinant of health, demonstrating that methamphetamine abuse is also contributing to the young hemorrhagic stroke in our community, with a higher prevalence of methamphetamine-associated intracerebral hemorrhage in the Native Hawaiian and Pacific Islander population. We have also shown gender disparities among the Asian population, showing the higher burden within the Asian men compared to Asian women, as well as some of the ethnic differences in the end-of-life care after a severe stroke. We talked about hemorrhagic stroke, but for the ischemic strokes as well, we have shown that ischemic strokes are occurring about 10 years younger. Again, a decade difference between Native Hawaiian and the Asians and non-Hispanic whites, and have shown that they also have higher burden of cardiovascular risk factors. And you can see here the higher LDL, lower HDL, and higher BMI, worse metabolic profile. I like this picture because it shows that with the right resources and support, everyone, regardless of our genetic makeup or baseline physical status, we can all achieve best health. And this is why I want to genuinely thank all of you here today. You're advocating for one of the most vulnerable population that we have, who are getting less than ideal attention. But I think with the right resources and support, we can help everyone achieve the best health outcome. I want to end by stating a quote from our hospital's founder, King Kamehameha IV. But let me remind you that so long as sickness shall exist, there will be a duty imposed upon us. I think we have a lot of work to do moving forward. So thank you so much for your attention, and I would like to welcome any questions through email or chat box or other mode. Thank you.
Okay. Thank you, Dr. Nakagawa. Next up, we have Dr. Auka Kanea, a professor of medicine, epidemiology, and biostatistics at the University of California, San Francisco, in the Division of General Internal Medicine. Dr. Auka Kanea is an expert in type 2 diabetes and cardiovascular disease prevention. She has focused her research on Asian American health disparities over the past decade. She is leading a study to better understand factors that explain the high rates of diabetes and heart disease among South Asians. Dr. Kanea, thank you so much for joining us today. The floor is now yours.
Thank you so much. It's my pleasure and privilege to be here with you, and I really appreciate that. I'm going to show you my slides. Hopefully you can see that.
Yes, we can.
Great. So I was asked to focus my talk on the cardiovascular health of South Asians, and I'm going to share with you what we've learned, just brief snapshots of what we've done in the study that we've been running for the last 10 years called the MASALA study, which stands for Mediators of Atherosclerosis in South Asians Living in America. So I think this is a great opportunity for me to kind of review some of the basic population sizes about how we define Asian Americans in the United States. And as you all know, it's a very broad, diverse group of people that originate from many, many different countries. About 23 different countries make up this umbrella term of Asian Americans. And the last major census data that we have is from Census 2010, when the total Asian population in the US, which does not include Native Hawaiians or Pacific Islanders, just Asian Americans, was almost 15 million. And you can see that the top 3 Asian subgroups then were Chinese, followed by Asian Indian, and then Filipino. And then here are the most recent estimates we have from 2018. We're awaiting the 2020 census data, which hopefully will be out soon. But the total Asian population in the United States increased to about 18 million over 8 years. That's 20% of an increase since 2010. And again, the 3 top Asian groups were Chinese, Asian Indian, and Filipino. And you can see the Asian Indians were actually one of the fastest growing ethnic subgroups in the United States. So what do we know about cardiovascular disease outcomes like heart disease by different race ethnic groups in the United States? And as Dr. Nakagawa mentioned, is, we've often just had very poor data among Asian American groups because they're all aggregated together. But here is a look at some disaggregated data from the Kaiser, Northern California area, where they looked at the incidence of heart disease by different subgroups. And here you'll see South Asians on the left. That includes Indians, Pakistanis, and Bangladeshis primarily. Then East Asians, which includes Chinese, Japanese, and Korean, are the 3 big East Asian groups. And then other Asian groups not well classified are shown in the 3rd bar, and then you'll see the Blacks, Hispanics, whites, multi-ethnic, and total. And I just want to make the point that following people enrolled in Kaiser, a very multi-ethnic integrated health system, they followed people for 10 years to see who had a heart attack, and the rates were highest among South Asians. And that was particularly true among South Asian men, shown in orange, compared to all the other groups of men, also shown in orange. The rates in women were about half, or a little lower than half, compared to men. And that's true for most groups. The rates of heart disease in women are always somewhat lower. So in 2018, the American Heart Association and the American College of Cardiology started to, do a more in-depth look at cardiovascular risk factors in South Asians, and they, looking at all the data that exists also from the United States as well as other parts of the world, they determined that South Asian ethnicity really is considered a high risk or a risk enhancing factor. And they've put this into the cholesterol guidelines so that when physicians and health providers are determining who are, patients at highest risk, that we need to be more aggressive about, not only with lifestyle changes that affect diet and exercise, but also with medications that we can use for prevention, such as cholesterol lowering medications or aspirin, that we want to, highlight people who are highest risk, and South Asian ethnicity was added as one of these risk enhancing factors. So I'm going to show you why this was done and some of the data that we have uncovered in our MASALA study. So the aims of this study that was started about 10 years ago was to establish a prospective community-based cohort of South Asians in the United States to be able to determine all different kinds of factors that are associated with atherosclerosis. And by that, I mean hardening of the arteries, so a precursor to heart disease. And so we were looking at traditional risk factors like high blood pressure, diabetes, smoking, cholesterol, but also wanted to do a more deep dive to understand sociocultural factors, behavioral like diet, exercise, stress, and other novel risk factors. And we wanted to compare the prevalence of all these cardiovascular disease risk factors to 4 other US ethnic groups. So we partnered with a study called the Multi-Ethnic Study of Atherosclerosis. And I'll show you what that study consists of in the next slide. And our long-term goal is to really investigate the factors that we can use to decide who is at high risk of developing cardiovascular disease in the future. So we designed MASALA to include South Asians who were between age 40 to 84 years old. We received a grant from the NIH and were able to include 900 people. Then because we're interested in looking at what causes cardiovascular disease, we excluded those who already had cardiovascular disease. So people who already had had a stroke or a heart attack or any kind of procedures on their heart, like stents or surgeries, they were not allowed to be in the study because we're looking at, what precedes those things. And we only included South Asians, and we have 2 study sites. One is at my university in San Francisco, and one is in Chicago at Northwestern University. We did a pilot study that preceded the baseline exam, which was done in 2010 to 2013, and we just completed the second exam visit in 2018. And as I mentioned, I think one of the big strengths of MASALA is our partnership with the Multi-Ethnic Study of Atherosclerosis, which is a large NIH study that's been going on for now almost 20 years. They enrolled a slightly older age group, 45 to 84, and we went younger in MASALA starting at age 40 because we know that South Asians experience heart disease at a younger age, so wanted to capture some of that. And they have a much bigger study. MESA, they included 6,500 people, again, with the same criteria, no existing cardiovascular disease. So we are comparing apples to apples between these 2 studies. They have 4 race ethnic groups. So that includes whites, African Americans, Latinos, and Chinese Americans. And they did the study in 6 sites with one in New York at Columbia University, one in Baltimore at Johns Hopkins, one in Chicago, where we have our study going at Northwestern, a site in Minnesota, site at UCLA, and one in North Carolina at Wake Forest University. They started 10 years before MASALA in 2000, and they were doing their 5th exam when we did our first exam visit. So here's what we've accomplished so far in MASALA. The first exam, as I mentioned, we brought in 906 participants to really classify them with blood tests, glucose tolerance tests, doing a CT scan of the heart to look at the hardening of the arteries. I'll show you some pictures of that. Then we got different grants to look at their social networks because we're really interested in sociocultural factors that may, modify risk or give people, higher or lower risk at developing heart disease. We brought everyone back in 2016 to do a second wave of data collection in them, and we added 258 new participants at that time. So our total cohort size is about 1,164 people. And we're hoping to get funding in the future to be able to do a third wave of exams with different cardiovascular tests. This is the only longitudinal South Asian cohort in the United States. And this is, set up to really look at factors that can predict who develops a disease in the future. So who are people in the MASALA study? 98% of the South Asians in the study are immigrants, and that's very consistent with immigration data that have been captured in the census and other large surveys. 84% were from India, and about 5% are from Pakistan and 1% from the other South Asian countries. And you can see that there's other diaspora countries where people were born in parts of Africa, Fiji, and other places around the world. So only 2% of our study participants are second generation immigrants who were born in the United States. What about levels of high blood pressure? So as Dr. Nakagawa said, high blood pressure is very common in some ethnic groups. And what we found when we compared the South Asians in MASALA in this first bar in orange to the other groups in MESA was the highest rates of hypertension were in African Americans in MESA, about 59%. The second highest were in the South Asians, and then that's followed by Latinos and whites, and Chinese Americans had the lowest rates of high blood pressure. And again, we've normalized this so that everybody is in the same age group, 45 to 84. We dropped out the participants in MASALA who were between age 40 and 45 when we do these direct comparisons. How about diabetes? The rates of diabetes in South Asians were the highest. And here in the red oval, I'm showing you the adjusted prevalence. That means what percent of people in each group have diabetes after you adjust for things like differences in education and family income and smoking, alcohol, body mass index, exercise, other factors that could be the reason people are developing diabetes. And we found almost 27% of a prevalence in South Asians compared to 6% in whites, 16 in African Americans, 14 in Latinos, and 16 in Chinese Americans. So again, this has been shown before in several different studies. Diabetes is a big risk factor in South Asians. We have also done a look at the newest data from the US large representative study called NHANES. We've aggregated data over a 5-year period, 2011 to 2016, and then broken up the new data that they have been acquiring in Asians into these 3 or 4 buckets: East Asian, Southeast Asian, and other Asian. And you can see when you aggregate this data for Asian groups, they look like they have very, much lower rates of diabetes, certainly higher than whites, but lower than Hispanic and African American. But when you disaggregate this very diverse Asian group into at least the buckets that we could do with this data, you can see that South Asians and Southeast Asians, primarily Filipinos here, and South Asians had the highest rates of diabetes, almost as high as the Latinos. So back to MASALA, comparing to MESA, we looked at all the different behaviors that were, measured in these 2 studies, and South Asians and Chinese had the lowest rates of smoking, and that's great. That's great news because this is a totally modifiable risk factor. We're not doing so great in smoking rates in the African American and Latino populations in the U.S., but certainly in the immigrant South Asian and Chinese populations, the smoking rates are much lower than what you see in native, countries in South Asia and China. Alcohol use was also fairly low or moderate in the 2 Asian groups here compared to whites, blacks, and Latinos, but exercise was the worst among South Asians. And this is using a questionnaire when we asked people what types of exercise they do every week, how many minutes, how vigorous the activity, and we did kind of a calculation to look at how many metabolic equivalents they were spending on exercise. You can see that the South Asians were dismally low compared to all the other groups. These stars just show levels of statistical significance. So that is a very modifiable risk factor. Again, there's a lot of diabetes, there's a lot of high blood pressure, and there's terrible levels of exercise in South Asians. What about foods? Now, most of you may have sampled South Asian foods at restaurants or friends' homes, and there's a big variety of South Asian foods, and so we really wanted to be able to capture that accurately in this study because food depends so much on the region of South Asia that you come from and family and traditions. So we asked about 163 questions that were about dietary intake, and using all this data, we looked at the patterns of diet that emerged in our participants, and we found 3 major dietary patterns. And about a third of the population was consuming a diet that was rich in animal protein, shown here on the left, with different types of animal protein and more Western foods. So like your continental types of foods like pizza, pasta, burgers, etc. A third of our study population was consuming a more traditional South Asian diet, which includes a lot of fried snacks and sweets and high-fat dairy types of products. And then a third were consuming more of a prudent diet, that's fruits, vegetables, nuts, and legumes. And this was kind of random, that it was a third, a third, a third is the major dietary pattern. And when we looked at which of these diets was associated with cardiovascular risk factors, what we found was that people consuming this animal protein Western diet had higher weight and bigger waist circumference, so more obesity in this group. People in this middle group, the fried snacks, sweets, and high-fat dairy, had higher blood pressure and lower HDL cholesterol, which is the protective cholesterol. So these are abnormal metabolic factors in these 2 groups compared to this third prudent group. And what's interesting about South Asians is about 40% of the people in our study were lifelong vegetarians. And you would think that most vegetarians probably fall in this last group here, fruits, vegetables, nuts, and legumes consuming. Maybe, but actually about half of the vegetarians were in this middle group, this fried snacks, sweets, and high-fat dairy, and the other half were in this group. So that is quite interesting, because if someone just tells you they're eating a vegetarian diet, especially if they're South Asians, don't assume that that's necessarily healthy. So we looked at this a little bit more about plant-based diets, because we know that there's healthier plant-based foods like whole grains, fruits, vegetables, nuts, and legumes, and there's less healthy that are refined grains and fruit juices, potatoes, other root vegetables, sweets and desserts, and sugar-sweetened beverages. And we looked at people who were consuming healthy plant-based foods versus less healthy, and who went on to develop diabetes. And what we found was, if you look at this diagram, it shows you the odds of developing, well, of having fatty liver, which is also a metabolic problem that exists in a lot of Asian groups. People who were consuming more of these healthy plant-based foods on the left column here had lower risk of having a fatty liver, and people consuming the healthy plant-based food had a lower risk of developing diabetes after 5 years of follow-up. And the people consuming the unhealthy, in the red plant-based diet, actually had a slightly higher risk of developing diabetes. So I think we can say with a little bit more certainty that, you know, there's a difference between the quality of foods people eat when they're eating a plant-based diet. So we need to be much more specific in our public health messaging about dietary changes, and it needs to be culturally adapted, because people are not going to understand if you say you need to eat more plant-based foods or more of a vegetarian diet if they were eating that diet that was full of, you know, the deep fried foods and high fat and high carb type of foods. So as Dr. Nakagawa mentioned, that we know that Asian ethnic groups in general have low body mass index, but there are a lot of hidden fat stores. And that means that the people can put fat in places where we were not supposed to have fat deposited, like fat around the heart, pericardial fat, fat in the muscle tissue, fat in the liver. I've already showed you that, you know, fatty liver can be affected by the diet you eat. And then fat around the organs of the abdomen called visceral adipose tissue. So in MASALA, we measured how much fat there is in these places using CT scan technology. And what we found was that South Asians store fat in all of the wrong places. And here again, I'm comparing MASALA in yellow to the 4 groups in MESA. And in the top left panel here, visceral fat, that's the fat around the intestines, was highest among the South Asians compared to the 4 MESA groups. Fat in the muscle was highest in the South Asian compared to the 4 MESA groups. And then fat in the liver was highest also in the South Asians. This is an inverse variable where the attenuation being low means that there's more fat in the liver. And here, this is total lean mass, which is muscle mass, which is a healthy place to have, more muscle. South Asians had the lowest muscle mass. And this is probably related to the fact that they were also having the lowest amounts of exercise compared to the other groups. So lastly, I want to show you a few slides on this atherosclerosis measurement I mentioned, which is the precursor for heart attacks. So we did CT scans of the heart, and this is a cross-section through the heart. And here in these white arrows are pointing to coronary arteries in the heart, and the white shows calcium that is on the plaques that have formed in the arteries. And the process of developing these calcified plaques starts pretty early in life, probably in the 20s and 30s, where there's a small deposit here this is an artery, a cross section through an artery. And you can see there's a little plaque that develops here with a calcium shell, and then a lot more calcium is put onto this plaque to try to stabilize it. This is a natural process the body is doing, trying to stabilize the plaque. And then what happens is as we age, the plaque can become vulnerable and it can rupture. And the process of the rupture of the plaque can cause platelets in the blood that's coursing through this artery or blood vessel to stick onto that ruptured plaque to cause a clot. And when the clot completely obstructs the blood flow, that's the heart attack. That's when there's a lot of pain and there's parts of the heart that don't get blood supply. So when we're measuring calcium, we're talking about this right here that is a setup for someone who is potentially going to have a heart attack in the future. So when we measured coronary artery calcium by CT scan in the men and women in MASALA, I'm comparing them here to the MESA 4 groups. Red is the South Asians, and this is across the age groups from 45 to 80. The red and the green lines track almost identically here for the men, showing you the amount of calcium in the plaques of the arteries is about the same for whites and South Asians after the age of 60. I mean, they basically are about the same lines. There's no significant difference here. But the 3 other groups, so the Latinos, African Americans, and Chinese Americans, had quite a bit lower calcium deposits in their heart compared to these 2 groups. For the women, the white women seem to have somewhat higher rates of calcium plaque, especially after the age of 65, and the South Asian women were somewhat in the middle compared to the other groups. So this is useful because this may be another way to determine who is at higher risk. It's how much calcium there is in their arteries. So I'm just going to sum up here with some of the key lessons we've learned. South Asians have higher prevalence of cardiometabolic risk factors, and maybe it's this adverse body composition, which I showed you had more fat in all the wrong places. That may be what's driving this problem. The CAC burden and progression seems to be greater among South Asian men than many other ethnic groups of men. I didn't show you the CAC progression data. After 5 years, the South Asian men had faster CAC progression, greater numbers of CAC than even the white men. But there are several modifiable risk factors, and I think that's where we really need to get the public health messaging right. And that is that you can do something. This is not an inevitable thing. You can change your diet to a more prudent dietary pattern using more healthy plant-based foods. We know that that can help prevent diabetes, which is one of the big risk factors for heart disease. Exercise more, because that will help increase the lean muscle mass and decrease some of these abnormal stores of fat around the body. I didn't show you some of our data about traditional cultural beliefs, but that can be influential in what you're eating and what you're doing. So having more of a moderate cultural belief structure actually was associated with lower risk and anxiety and stress reduction. In some other papers we've written from the study, I couldn't go into all the details, but I will show you our website, which we update weekly, and that has all of our publications, and we write blogs about each paper that we put out so that it's very accessible to the average person to make sense of some of the data that we're publishing. So I do encourage you to go, and we have lots of health tips here for South Asians that is very culturally appropriate. I want to thank everyone who has been a part of the MASALA study for the past 10 years, especially our study staff and investigators and the funders that have been primarily the National Institutes of Health. I'm happy to have you communicate with me by email. I do want to show you one new study that we are doing to really help give the voices of Asian American and Pacific Islanders some more weight in research that we do. We are working on something called the CARE Registry, and it's a partnership with many universities of California. San Francisco is leading it, but we have UC Davis, UC Irvine, and lots of community organizations all around California. And the goal of CARE is to pave the way for meaningful inclusion of AAPI in clinical and caregiving research, because what we found is, most research studies include less than 1% of Asian American Pacific Islanders. And if we don't have representation in these studies, we're not going to learn anything about health and disparities in these groups. And so this registry is simple because we're trying to get 10,000 Asian American Pacific Islanders to enroll as a way for us to share their names with study investigators who can contact them for future research that they're doing, and people can choose to join that research or not. But we're just enrolling AAPI, any adult, as long as they can speak and read English, Chinese, Cantonese, Korean, or Vietnamese, they can enroll. And there's many topics of research that they may be contacted for. So I would really encourage you to use your networks to disseminate this information about CARE Registry. It's just a simple website, and I will post some of that information on the webinar as well. So with that, I thank you for your attention.
Thank you, Dr. Kanea. We would like to extend a final thank you to all of our presenters. We greatly appreciate the expertise each of you are able to provide. Thank you to Novartis for supporting NAPACSL and this webinar. Mahalo nui to everyone. And thank you for participating in today's webinar. As a reminder, please email Irene Kawanabe at irene.kawanabe@ncsl.org with any questions, and a recording of today's webinar and presentation slides will be available on NAPACSL's website within a week. Mahalo and thank you, and stay safe.